appreciate you guys having me today. I'll just give you a quick background. I'm in private practice. I'm at a physician-owned hospital system. So I had to fight for getting this product into my hospital, even though I'm the one still paying for it. It was that important to me. I'm very passionate about this. I do about 1,300 primary and revision cases a year, so we get a lot of data, and hopefully we'll show you some of that. It's pretty compelling data. So here are my disclosures. Interestingly, I described to a large language model how I use Prontosan in the OR and then asked it to provide me with an image based on the description of my use. And that picture on the right is what you see there. I thought that was pretty interesting and probably pretty close. So here's the problem, right? Surgical site infection remains the single most important problem we have in all surgical specialties. 50 million surgeries a year, and if you look at that, just that 3-year time span, 2006 to 2009, almost 2% of those cases got infected. That is a staggeringly large number. When you start to break it down into certain surgical specialties, their infection rate's even higher. But look where we're at in orthopedics. Now, we certainly like to be the leaders in a lot of things, but this is not the one we want to lead in, and we're crushing it. So we are not making a significant difference when we talk about everything that we've done prior to Prontosan. These numbers are, especially for somebody like me who's in a bundled payment system, these are crushing numbers and crushing data, right? So what am I trying to avoid? Readmissions, ICU admissions, and mortality. We're not doing so good there. When I look at the financial impact of that, surgical site infection is the single most expensive event that we have in surgical medicine. If you think about $90,000 on average per surgical site, periprosthetic surgical site infection, and then you add that to the numbers we talked about previously, that is a massive amount. $10 billion annually is from several years ago. It's about $30 billion today annually. Average length of stay, almost 10 days. In a small physician-owned hospital, that is unsustainable for our facility. We don't have the beds. We don't have the ability to care for a patient like this who's this sick. So when I started down this road, I was wondering, how did the guys that I trained under pick the irrigation solutions that they picked? And it just seemed to be, well, that's what I saw during my training, or that's what we have available to us in the hospital. And it was a myriad of all these things. Every single surgeon in this room has put almost every bit of this into somebody's hip or knee, guarantee you, hoping that it's going to make a difference. Chlorpactin smells great. Hydrogen peroxide makes bubbles. So I feel like those things maybe move the needle and they're doing something. For me, I had no reasoning for why I did what I did. So when I got out into practice, I started to think, okay, what am I going to use? I'm a, some is good, more is better kind of guy. So I developed this protocol. This is my revision protocol. So I would do a 5-minute soak. I'd start with hydrogen peroxide. I read some data that said if you do hydrogen peroxide before you do chlorhexidine, you get better effect from the chlorhexidine. So I thought, hey, if one of these things is good, I'm going to use all of them. I'm going to let them soak for longer than 90 seconds, which is the indication, and I'm never going to have infections. I'm never going to have complications. Well, that certainly wasn't true. Unfortunately, this paper came out about a week after I started using this protocol, right? So it crushed all of my thought process behind my reasoning. So when they looked at combining chlorhexidine and Dakin solution, we get a toxic precipitate. When you combine chlorhexidine and hydrogen peroxide, same thing. When you combine Dakins and hydrogen peroxide, now you get a potentially toxic gas in the operating room. And I was using all of this, and I was seeing all of this. I would develop a precipitate in the wound. If I added acetic acid to this, the tissue would turn grayish black, and then a gel would form on the soft tissue. The first time I did that, I was absolutely terrified. I irrigated that, trying to irrigate that grayish black color off the tissue, and guess what? It didn't come off. That was dead tissue. It's certainly not what we're looking for in the face of a potential infection. So what do? Do I just take this patient's skeleton, soak it in a vat of whatever solution? Well, here's the answer, and the very wise Dr. Freumsen taught this saying to me: the solution to pollution is dilution. We've all heard somebody say this at some point in our training, but like all great fellows, I added to what he taught me, and this is the real answer. It's the solution to pollution is dilution with the right solution. You can't just dump anything in there. You can't, 20 liters of saline isn't better than 2 liters of saline. So you got to pick the right solution, and you got to know why you're using it. So I said to myself, what are the things that I want in the perfect irrigation solution? I want it to work fast. I don't want to be in there for an hour staring at the clock, waiting for this magical soak to break down biofilm and kill whatever's in the knee. I want it to be broad spectrum. So I want it to work against gram-positive, gram-negative fungi, yeast, and viruses. I want it to be bactericidal. I want it to be bacteriostatic. I want at least a 5-log reduction in my colony-forming units, and I needed to sustain that inhibition of growth over time. I needed to be effective against biofilm, and I needed to prevent future biofilm formation, and I needed to work in the face of what we have in every surgical site, which is blood, protein, fat, and debris. So this is the thought process. This is one slide that kind of summarizes his entire talk. These are the things that go through my head when I'm trying to bring a patient to the OR. Doing this 1,300 times a year is pretty difficult. So managing all this is overwhelming. If you don't have a patient that's willing to engage in this process, you're already losing. So I assume that my patient has done none of the things that I need them to do, and I try to optimize everything that I can do in the OR and after surgery to get them a good outcome. So this is how my journey began, right? So, and by the way, for anybody who's worried about AI taking over the world, that's an orthopedic surgeon with a stethoscope, so clearly has a lot of training left to do. So we're okay for now. I found a paper called The Consensus on Wound Antisepsis, published 2018, and it had all this stuff that I was looking for. So it kind of had a little bit about every one of these irrigation solutions. When was it effective? In what scenarios was it best? How long did you need to soak? What environment did it, was it optimal for? I had never heard of this paper. I had never seen this paper, and it was game-changing for me. I had no idea what PHMB was. Never heard of it, never seen it, and so I started looking at the data, and it's pretty overwhelming. PHMB had greater antimicrobial effect than chlorhexidine, and if you look at Earcept, 0.05%, they're looking at 2% chlorhexidine, 3%, 5% chlorhexidine. Put that in a knee and see how well your wound heals. You're in trouble. It was better against biofilm formation. It broke down biofilm better. When you get to 2 or 3 or 5% chlorhexidine, you start to see severe reactions. I have 2 patients who had intraoperative reactions that we had to actually stop the surgery and get them to recovery from a severe reaction to chlorhexidine. It's not tissue toxic. In some countries are even taking that tissue toxicity or taking chlorhexidine away because of that tissue toxicity. So the consensus, right? Where are we going with this? Well, PHMB was the #1 choice to prevent surgical site infection, the #1 choice for critically colonized wounds, the #1 choice for multi-drug resistant colonized infected wounds, and the #1 choice to decontaminate acute and chronic wounds. I think that covers everything that we're trying to do as surgeons in the operating room. That's #1. That isn't an industry-sponsored paper. That is a nationally recognized board of professionals looking at all the data and coming to this conclusion. It's the most frequently used antiseptic in orthopedic surgery across the world. Why isn't it that way here? Most of us are hearing about PHMB for the first time maybe today. That's a shame. PHMB appears to be the best eligible antiseptic for patients who already have a septic joint. There's significant decreases in MRSA when you use PHMB in a clean surgical site. So I won't go too far into this because I'm not smart enough to do this part, but there's a surfactant that has a hydrophilic head and a hydrophobic tail. That allows the surfactant to capture this debris that we're irrigating out in the wound and take it out instead of leaving it in. So that's a really, really important part of this. So when you combine PHMB with betadine, you get a really powerful product. This is my protocol. So I wanted to develop a protocol, and then after this, I wanted to find out, am I really making a difference? I didn't want to just take, anecdotally, we all drink the Kool-Aid every once in a while on a product and fall in love with something. I fell in love with this product immediately. You could see a change in your wound. When you irrigate, you see a dilation of the arterioles, the tissue pinks up, it looks healthier. It's one of those products that you can see working, which always makes me happy. But I started off using saline through the case and then Prontosan in the end. And my PA said, why are we doing that? We already know saline doesn't work. Why don't we just skip the saline? So we went to a 1 liter bottle of Prontosan. When we make incision, we use Prontosan. When we open the joint, we use Prontosan. We irrigate through the case, and at the end of the case, we irrigate with Prontosan and we leave it in. You do not have to rinse this product out. For revisions, I do the same thing. I just use 3 liters instead of 1 liter. You saw the data previously. You don't have to leave it soaked for forever. 60 seconds, it's bringing those numbers down immediately. So I thought, gosh, I love Prontosan. How do I use more Prontosan? That made Jason very happy. He loves that question. Well, I started to look at the use of the wound gel. So they have a wound gel that's a little bit waterier, and then they have a wound gel X, a little bit thicker. And I wanted to see if the wounds that I was seeing in the office, if I could make a difference there. Every one of us is writing prescriptions for doxycycline and other antibiotics. We're not moving the needle. Many times we're doing that for the patient's comfort level. We know we're not going to really do much to heal that wound with that antibiotic, but we do it every day. We're not practicing good antibiotic stewardship. And so I thought, let's see if this makes a difference. So the very first patient that I used wound gel on, this is the outcome. This lady actually called me the next day and said, can I buy stock in this company? It was dramatic. It was overwhelming. I bought my first case of Prontosan wound gel that day. So that's in my office every day. Every patient who comes with, delayed wound healing, we give them Prontosan gel, we give them a protocol, they do wet to dry dressing changes. It's easy to follow and they can see it working. That's the biggest impact for me. If they can see it working, they'll be compliant. So then a brilliant surgeon decided to study whether this really works or not. So surgical site infection, obviously we've established, that's a big problem. So the protocol that we developed earlier, I decided to take a look at. So we looked at antimicrobial prophylaxis guidelines for SCIP. Every patient followed the same SCIP guidelines. So we tried to standardize that portion of it. Then we took 308 consecutive patients who were considered high risk. We defined high risk as a patient who had 3 or more diagnoses from the Charleston Comorbidity Index. And then we went and looked at their data retrospectively from the registry. And over an 18-month period, we had 0 of those 308 patients with a periprosthetic joint infection. Now, I think that 140,000 is a gross underestimation of what we saved the hospital, but the journal didn't like the number that I put in there, so we decided to play nice. Then I thought, well, look, let's see if that same data, if we get that same data with revisions, because really revisions are a much higher risk procedure, they're a longer procedure, so we tried to duplicate this study. we went and looked at a retrospective review of our prospective data through the American Joint Replacement Registry over about a year's period, 85 revisions, 72 knees, 14 hips. 73 of those cases were for aseptic reasons, and then we had 12 or 13 for deep infections. We followed that same SCIP guideline. We grabbed that data from the registry so it was independent of my ability to have bias on that data. And then we had 2 patients we lost to follow-up. And then at 90 days, we collected this data at first, and we had 0 infection rate at 90 days, but that wasn't very exciting to me, so we decided to hold off and collect that data at a year. We had 0 infections or reoccurrences from that patient population at a year. I didn't expect the data to be this good, and I'm really impressed by what we found. So if we're going to circle back around those key factors that we talked about earlier, I think we're going to check the box on every single one of these. There isn't a single thing that we wanted to accomplish that we're not accomplishing with a single irrigation solution. No rinsing, doesn't damage our implants, and here's the big one. There's no resistance, and it works synergistically with antibiotics. If I gave you that list and said, I got one solution, it's in this little bottle, it takes about 90 seconds for it to work, is anybody not willing to give this a try? I think you're making a mistake if you don't. This is our opportunity to make a difference. This is a huge impact on our patients' lives. There isn't a single guy that can't think of somebody right off the top of their head that lives were destroyed by a periprosthetic joint infection. I think we all could come up with a pretty long list. And when it happens to a patient, it's devastating. And I know as a surgeon what we're about to go through over the next 2 years. If this bottle saves even a percentage of those patients from going through that, it's worth every penny. It's safe, it's efficacious, and it's certainly cost effective. Thank you.